So I'm very happy now and delighted, in fact, to introduce our first speaker, who is Professor Andy Shennan, Professor of Obstetrics at King's College, which I've said before, Trustee for APEC, and he's based at St Thomas's. He's clinical lead of the Maternal and Fetal Research Unit and specialises in clinical trials in antenatal intrapartum care. I might also say today is Clinical Trials Day as well, which is interesting. Support there. Andy's research interests include interventions to prevent preterm birth, preeclampsia, encouragement of normal birth, and the use of blood pressure monitoring. He chaired the Department of Health Committee on Blood Pressure Monitoring in Clinical Practice and sits on the relevant committees for the International Standardization Organisation, ISO, and the British Hypertension Society. He also advises the World Health Organization on perinatal research. So I'm really pleased to provide you with the screen and the floor, Andy. Thank you.
Great. Thank you very much, Sue, and thank you for your comments. I think we need to be mindful that this is a serious condition, and I only heard today another one of our colleagues, a young female doctor, is gone into hospital quite seriously ill, and I think that's just a sobering reminder that this hasn't gone away and probably isn't going to go away. But I think we have to kind of move on, and it's a really great opportunity here to be able to talk to you. And APEC, which is a charity dedicated to pre-eclampsia, has always had a very close and fruitful relationship with the midwives who are absolutely key in maintaining the success we've had in managing pre-eclampsia over the years. And I think it's critical at this time that we maintain that success and don't let this virus change what has been achieved. So what I wanted to do in the next few minutes is maybe just go through the relative merits of pre-eclampsia management and how it impacts on COVID and what we should think about as we sort of work our way through this quagmire. So I'm just going to sort of very briefly go through what pre-eclampsia can sometimes be viewed at in terms of its evolution and what we know about it and how that equates to our clinical knowledge and management. So we know that this is a disease that probably starts very early on in pregnancy, and we don't know it's there until people develop hypertension and proteinuria. Sometimes that can be quite early when it tends to be more serious. We don't always get symptoms with it, but those symptoms come on variably a little bit later. But what is almost invariable is a crisis that means the mother has to be delivered and the baby has to be delivered. And if that doesn't happen, it can be fatal. And I think we sometimes forget how serious it is because we manage it so well. And for so long now in the UK, thanks to the universal healthcare provision and the midwifery structures we have, this has been a huge success. And I think we should think critically about what we've achieved and how COVID might impact on this. And the thing that I always like to show is that it's only a couple of weeks between somebody developing the sort of signs of preeclampsia and a crisis happening. And if you develop preeclampsia, for example, at 34 weeks, it's only about 5 days before you have to be delivered because of something serious. And I sometimes think we forget how serious a condition it is because people are under our nose. And with this care being looked at critically and the contact we have with women, I don't think we should forget this. Because preeclampsia is basically there, but we don't know about it, there are new tests, and I want to just very briefly touch on these and how they might be used in the near future now, particularly with COVID affecting the way we might structure antenatal care. Now, this slide actually illustrates the huge success we've had over the years in managing preeclampsia. And you can see from the 1950s to the 1980s, there was this massive decline in maternal mortality related to blood pressure problems. And this is probably a combination of factors, including basic sort of healthcare and societal improvements. But even from 2008, there has been this steady reduction. And that's probably related to some focused issues like, aspirin prophylaxis and maybe timing of delivery, not letting people go past 37 weeks if they have the disease. And what it translates into is that now in the UK, only about 1 in a million women die from this disease, which is perhaps some of the best statistics in the world, and something that I think we can be very proud of. And that's largely due to the due diligence and the careful management and care that midwives provide in our healthcare structure, which is something we can be very proud of. Now, in contrast, if you look around the world, here is a geographical map that illustrates mortality around the whole world. And you can see that these 60,000 deaths that occur in preeclampsia are largely in Africa and Asia. And the success we've had in these high-income countries isn't because we have wonderful drugs. It's very simple things like identification and timely delivery. And drugs like magnesium sulfate and antihypertensives, they only ameliorate the disease in the very short term. They don't actually save lives particularly. And it's just a sort of a temporary measure until one can actually instigate delivery. This is data that I actually have recently got from around low and middle income countries in the world, showing the chance of people dying from hypertensive diseases out there in places like Africa and Asia. And these figures are quite startling. You can see they vary a lot depending on where you are, and some countries are worse than others, but in absolute terms, they are relatively high. And I just wanted to share that in the context of what goes on in the UK. So we know that people die from sepsis in the UK. And I particularly show this because I looked up the sort of deaths that happen from things like influenza and from pneumonia, which is what COVID is causing. And they do occur, but they're relatively rare. And only about 1 in 200,000 1 in 200,000 women will you get a death related to that. And COVID has impact on that, perhaps about a 5-fold increased risk. And one thing about COVID is that it does affect people who are older. I think we all know this. But what's interesting, and this slide shows that the influenza pandemic in 1980, if you look at women of reproductive age, which tend to be between the ages of 20 and 40, influenza, for example, in 1980 was far more likely to kill a pregnant woman than, say, COVID. And so pregnancy itself, although young women do get this disease, as we've all seen, it is relatively rare compared to other conditions. And I think it's important to keep this in perspective. What I actually did for this talk is put together this data, which is the current, the prior deaths from influenza, pneumonia, and non-genital sepsis was about 1 in 220,000 women. If you look at COVID from the UCOS data, for every 16,000 deliveries, there's been 1 woman die. So obviously that is bad and much higher than you would expect from pneumonia and influenza. However, if you look at the equivalent mortality and average across low and middle income countries, it's 1 in 2,000. What this actually means is that COVID deaths are not nearly as common as hypertensive deaths currently in Africa. And what we don't want to do is slip back into sort of care whereby people are missed, which is a common problem in Africa and Asia. And we want to maintain this 1 in a million risk, and we've got to be very careful about this. And what I've observed over the recent weeks is that quite frequently women will come up and say, oh, well, nobody has seen me. I've had my calls, but nobody's done my blood pressure, nobody's checked my urine. And there's anecdote after anecdote. Just last Saturday, one of my registrars said that a woman had come in with a systolic of 190 and 4 pluses of protein, failing completely well, and said that no one had seen her for weeks. And so this is something we really, really have got to watch and not slip back into. What I wanted to share with you is our local experience, and this is from Guy's and St Thomas's, which is in the middle of Southwark, Lambeth and Lewisham, which happens to be the worst affected area in London. London happened to be the worst city in the UK, and UK perhaps one of the worst countries in the world. So this is the worst of the worst, actually, and it's not that bad. So we've had less than 30 cases in the entire pandemic. Yes, 3 people got seriously ill, nobody died, and all the other units in London have a very similar story here. And this is not the tsunami of disaster that we were expecting. And we have to balance this. And although this has been a success through the isolation, and we have to applaud that, we have to balance this against the potential of causing harm by the care that we are not going to give. And this is the point you were making, Sue, and I think this is really important. And again, if you look at the data as it came into our hospital over the pandemic weeks, you can see the red ones. There was only, a few positive cases sporadically, some weeks that there were none. And in the last 2 weeks, we've tested every single woman who's been admitted to the hospital. That's 170 79 women, and there hasn't been a single positive case. So I think we can take some solace from that this is turning around. We have to think critically about the other care we give and not result in a problem which has now become a reality. So in order to do that, I'm actually going to talk a little bit about aspirin. Aspirin, we know, if targeted to high-risk women, will reduce the risk of early onset and serious preeclampsia through the sort of production of improving the prostacyclin thromboxane balance. Without going into too much detail, I just wanted to share a couple of interesting points that you might find useful. One is we do now know that taking aspirin at night does improve all these outcomes. Such a simple thing to say, take it at night instead of the morning. We're not fully aware why, but there are some plausible reasons. And so that's one thing that I think we should say if someone has been prescribed low-dose aspirin. The other thing is interesting evidence coming out about the slightly higher dose. You'll probably see women increasingly be given 150 milligrams, particularly if they're overweight, in order to reduce the risk. And this trial, the Aspirin trial, has really been the one that has demonstrated this. So 150 milligrams a day given from early on at 12 weeks, taken till 36 weeks and given at bedtime, and targeting women who've been identified by an algorithm or who are at high risk. And you can see that in this study, they can reduce preeclampsia occurring before 32 weeks by 90%, and preeclampsia that occurs before 34 weeks by 80%, which is the preeclampsia that really matters. So these are things that you'll start to see coming in. But my appeal to the midwives is that we see people early enough before 16 weeks, and we don't miss the opportunity to prescribe high-risk women aspirin because it seems to be benefit those who take it early. And this is something that we may slip away from with the COVID antenatal care issues. And finally, this paper that's literally just come out this year in the Lancet, showing that nulliparous women in low-income countries routinely given 75 milligrams of aspirin significantly reduced the chance of being delivered early, and mainly because it reduced hypertensive disorders. So there was more than a 60% reduction in that of delivery before 34 weeks with hypertensive disorders. So low-dose aspirin has got a role. I just wanted to mention PLGF. This is an angiogenic marker, which is now being rolled out across the UK. Some of you may be starting to see it. The great thing about it is that if you have a woman who may have preeclampsia, in other words, she has hypertension or symptoms, and you do this blood test between in early pregnancy, particularly around about that critical time, 28 to 34 weeks. If it is low, you are much more likely to need delivery soon. And if it is normal, you are very likely to go some months before there's a problem. And this may help tailor our antenatal points of contact, which we're trying to do in the COVID situation. So here's the data. So about 1 in 4 women will be very high risk. That's they have a red level. They will, on average, need delivery about 9 days later. But importantly, over 40% of women who have suspected disease will be normal, and they will go a couple of months before they need delivery on average. In other words, a blood test simply tells you they're normal, and they do not need to have this intensive care monitoring. We know from our clinical trials that using these blood tests in clinical practice actually improves outcomes. And so it translates into better care that actually helps the mother and the baby. The other interesting area now is self-monitoring of blood pressure, which is a simple thing to do. You give women monitors, and there are guidance which you can access, particularly from the RCOG, RCM, that tells you about who to test and how to do it. But essentially, it's people who've have underlying chronic hypertension who benefit from this most. I think the next group are those who you would target aspirin to. So, for example, here's the list that NICE give to target aspirin, and they'll be great to give home monitoring to, so we don't miss them developing preeclampsia. And if there were enough monitors available, of course, everybody could benefit from being monitored at home. The trouble is that they are a bit in short supply at the moment. And these algorithms are out there, so you can actually access them and give advice. Please use a monitor that's validated in pregnancy. These are available on these websites. They tell that unfortunately preeclampsia means that a lot of automated devices aren't accurate, and they underread blood pressure. And one of the devices we promote in APEC is this one, which actually has a traffic light system on it, which we've developed. And so you can tell women when it's red, call us, when it's amber, call us, and how quickly to act. So this is the Cradle VSA, and they are available from APEC. At the moment, we're out of stock, but there are more coming, and you can see we've put in the normal 140.90 for amber. I just wanted to finish off in the last minute or two by saying that we are still doing research out in Africa, because we realized diseases of hypertension, particularly around the world, are very serious and, relatively speaking, compared to COVID, still incredibly important. So we haven't stopped our research there. Obviously, we are sensitive to the staffing issues if COVID hits those environments, and we've left it up to local choices. But the research continues, and I think that's important to acknowledge. I think we've looked at ways, and there's a couple of videos that one of my PhD students has come up with, getting women to access care appropriately. And this is something that we need to concentrate on in the future. So if you go to the resources that are being dished out from this talk, you can actually look at these videos. They are nice videos, particularly in a low income setting. We are starting these new APEC International that's about to launch. It was going to launch with the Pre-eclampsia Day this week, but and in Kigali in June, which unfortunately has been cancelled. But please keep an eye out for this, and you can keep an eye on the APEC website. But let's not go back and increase these deaths that have come from the past. We have done incredibly well, mainly driven by the excellent midwifery care in this country. We want to keep the statistic 1 in a million and no worse. And please just be mindful about the relative problems of withholding antenatal care in the future. Here are some of the resources. I do just want to acknowledge the many, many wonderful people I work with, particularly the midwives. We have huge numbers of midwives on our teams who do a sterling job, and we at APEC acknowledge they really are the backbone of our success in this area. Thank you very much.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.